I'm going to move on to our next in that case, from Alison Walters. Alison.
My question is about care for those at the end of life. Research shows that most people would choose to die at home, and yet only a quarter of people currently are able to do so. What does the panel think should be done to allow people to die in the place of their choosing?
I remember in the 80s, Jack Ashley MP raising this, coming up with a great deal of research, which, if my memory serves me, it may not, shows that roughly the same figures applied then as apply now. What should be done? Ciarán, let me come to you first on this. What would Macmillan Cancer Support like to see being done? How do you get from there to here?
I think the surprise for me is that in areas where we do some relatively obvious things, we can get it right. If you look at the Macmillan service in Midhurst, the number of people who die where they want to die, mostly at home, is north of 70%. So it's not rocket science. It's happening in pockets around the country. The question is, why isn't it moving around the rest of the country? And it's really the absence of, in each place it'll be different, but some critical components. 24/7 community nursing. We know how to do it. It saves a fortune for the NHS, but it's not available everywhere. Only half of areas are covered. Then there are things like the support for carers that we talked about. There's identifying the patient who is dying. Amazingly, quite a few GPs haven't been told by the hospital that this particular cancer patient is terminal and therefore you need to be planning for end of life. So getting that planning right as well. And then it links back into the social care comment. If we want people to die at home, we're going to have to wrap some support around them. That's not really clinical care, that's mostly social care. We can do that, but it gets you into the space of free social care at the end of life, paid for by fewer people lying in a hospital bed at vast expense when they shouldn't be there. It's not rocket science, it's building an end-of-life care package in the same way we've built an end-of-life or a survivorship care package.
And am I right, if you're looking purely in financial terms, there are not only no losses to be made from achieving the objective that people want, there are actually savings to be made.
When we did the Midhurst work, we did the economics because that was how people were challenging us. It was 20% cheaper to provide a higher quality service which helped people die where they want to die, and roll that across the country, and we're talking tens of millions of pounds.
John, given that this is one of the most critical features of life and death, that people want to be able to die with their loved ones at home, not in the often, however well-meaning, appalling circumstances in a hospital ward, and given that there's no cost disadvantage and possibly a great advantage, and given that it's been wanted for so long, on the face of it, it would seem like a no-brainer.
Agree, completely agree. And to reinforce something that Ciarán has just said, often in those areas, those local authorities, those PCTs, now CCGs, where the percentage is not good, in fact it's poor, is often areas where there is a lack of coordination between health and social care. In many areas there is, I describe it as a sort of black hole between the NHS, between health services and social services, and indeed police and other services. We've got to mend that, and the hope is that the more localised CCG-led commissioning should allow GPs to tailor services to suit their communities. One disagreed with the structural reforms to a certain extent, but very much agreed with the new NHS focus on outcomes. In other words, not how many people were treated, but how well were they treated. And this increased emphasis on localism now, GPs leading the way, should help to address this and spread best practice, because that's what we need.
Diane, does that help solve the problem?
Well, what you actually want is much closer working all together between social service and the NHS, in effect actually pool the budgets, because it's about money. The reason it's so hard to go and die at home, social services don't want it, because then the costs will all fall on them. So rather your relative stayed in hospital. And I'm sure you won't mind me saying this, Andy Burnham was Secretary of State for Health and is now Shadow Secretary of State for Health, but he was a junior health minister when we were in government, and he had a sister-in-law that was dying of cancer. I think it was breast cancer. And she told the family the only thing she wanted to do was to be able to die at home. Now, Andy Burnham was a junior health minister. He said, sure, absolutely, no problem. He rang, he spoke to officials, he spoke to hospitals. It was not possible, and he was a health minister. It's a very rigid system, and until you, in effect, actually, merge a lot of the structure of the social services with the structure of the NHS, you'll continue to have this kind of table tennis with sick people and dying people.
Let me bring in our audience. I'll come back to our members of the panel in a moment. Yes, you've been waiting patiently as well. It's in the second row.
As somebody with an incurable cancer, we had this discussion at the last question time, Ciarán. Who actually starts a discussion on where you want to die? It all seems to be done at the last minute, everybody running around. Somebody should open that discussion very early on, so we can plan ahead and decide and look for what the services and resources are.
Why do you think that people don't open that discussion early?
I think we decided at the last meeting GPs were the best people to do so, but they really don't like to talk about that sort of thing. I mean, the health service is there to keep you healthy and keep you alive. They don't like death. And it's a very sensitive subject, but your local GP is the man with all the contacts with the local hospices, social services, the nurses, and I feel it's the best way. I would like my GP to have that discussion with me, so I have time to think and type it around.
I suppose the timing of that debate discussion is important, because if you do it very early in a cancer which may well, if you're fortunate, be cured, or certainly you will live a very long time with that cancer, it could be rather intimidating or cause of considerable anxiety. If you do it late, you have exactly the problem that you've just described. Does anyone have a thought about how you should do it? Yes, in the second row here with the white top.
Well, actually, on that point, my mother was wrongly diagnosed with cancer of the spine, cancer of the lungs, and her GP, my GP as well, referred her to a hospice. Now that put her on the wrong footing and was counteractive, because she then became incredibly negative when she should have been positively sort of focused on living. I'm saying a misdiagnosis, it actually turned out to be TB. But it's getting the balance right. I've had cancer myself, and I'm a firm believer, and in fact I've already written it sort of down for my partner in advance. I'm in remission, but in the event that I get a secondary, etc., I put it in writing. That was my own choice to do that. I've also sort of signed a do not resuscitate, and I think it's having the ability, and all of us respectively having open and honest conversations with our loved ones when we know the time is right. And who knows when the time is right, but I think you individually do know.
We'll just throw it back on the edge here. Yes, just there.
I had a friend who died last year who was a consultant in palliative medicine herself previously. She actually sent for another friend who was still working in palliative care and did her advance directive at that point. When she became really ill, and she was at home, she had a superb family set up, but the GP, who did not do 24-hour, 7 days a week, was in charge of the prescribing. And the hospice wasn't able to do the prescribing, it had to go to the GP. So she didn't get what she actually needed. Not only that, but her pain control wasn't good because she wasn't allowed enough in case she finished herself off early. And then within the last week of life, she was asked to sign a form saying she did not want to be resuscitated. Now, she'd been very clear right from the beginning, done it very well, but to put in it bluntly, they did rub her nose in it at the last minute. If you're now dying, we need you to sign this form.
And one more from here, and I'll come back to the panel. The guy on the outside just here.
Thank you. Jonathan, something that helped me through my cancer and my remission was having a very strong relationship with the team treating me, my haematologists, the consultants. I got involved in my treatment, and they encouraged me to become involved in my treatment, and that's what helped me steer the outcome of what I wanted. They were always asking me how I wanted my treatment to progress, and they took into consideration what I wanted, because it's my body and it's my cancer. And I think having a strong relationship with the team treating you is absolutely important.
This does take us absolutely into the heart of the matter of putting the patient's aspirations, needs, anxieties absolutely at the centre of the stage, rather than sometimes, as it were, in the footlights only. Sorry.
I mean, I think that's a very important point, that it's treating the whole person, not just the disease, and indeed looking beyond the person to the family as well, because there are many people on the journey, and if we're talking about end of life, there are others who are going to be suffering from bereavement as well. So the support that's put around the family is absolutely key. And in a way, the comments we've already heard, I think, really underline our sort of societal complex when it comes to talking about death. We're very, very reluctant to talk about death. We're certainly very reluctant to contemplate our own personal demise. And yet, the Dying Coalition, Dying Matters Coalition, I think has done some really good work already, voluntary sector led, trying to really get these sorts of things discussed. And I think it is about those relationships within those clinical teams, but it's not about the medicine, it's about the human relationships that really matters. I just want to pick up two things really. One, it's not 1 in 4, it's actually better than that, because there are an awful lot of people who actually die in care homes because they are their homes. So there are issues about making sure care homes really are homes and not just restrooms to the end of your life, and that they are places where the staff do have that capacity to be able to manage end of life.
So are you saying the figures are worse than that?
No, they're better. So
better?
42.4% of all deaths now occur either in the home or in care house.
Yes.
So there is a journey going on here. There is an improvement, but it's not by anywhere near enough. And one of the things that's going to drive, I think, this in the right direction. Back in 2012, we had the world's first ever national bereavement survey published in the UK. I mean, a lot of really powerful data. The second one is now just been out. Those things are being used to analyse the differences from one locality to another. Why is it that people are dying in such large numbers in hospitals in some places? What is the experience of the quality of the care? So that's being used by CCGs and others to actually drive some of these changes that Ciarán was talking about just now.
I think we'll is there anyone else who would like to come in on this who hasn't done? Yes. The guy with the hair that's my colour. Elegant.
I think most of us here, the fact that we are here, have very strong views about end of life. But I think it's down to the healthcare professional team. When you have been diagnosed without a doubt that you have cancer, you are then asked, well, how do you want to approach this? What your outcomes are? You should have the choice. You should be given the choice. You shouldn't be just left willy-nilly. I know men who don't want to know. They can't even tell their partners that they're going to die. They won't tell the family. So you've got that on one extreme, and yet you've got people like us who are prepared to talk and plan. So you've got to cater for everyone. But I certainly don't think there's a GP that should be told, allowed to discuss it with you. It should be the professional, healthcare professional, the team.
Your oncologist or your surgeon,
yes.
Or your breast care.
And I understand it is part of their training to do that, but a lot of them don't care to pick it up because they can't face it. Because it is an emotional time to be told, that you have got so many years left to live or whatever. But it's also part of your treatment, because if you fight it and take appropriate action, you can delay your fight.
It's interesting what you say, because it's also the case that latterly at medical colleges and training, this issue is on the training agenda, and yet despite that still there are those perfectly decent individuals who are become oncologists who find it extraordinarily difficult for one reason or another. Ciarán, we've touched on this quite a bit. Do you see, and it came up at your last session as it were, do you see a way through this?
Perseverance, I think. The most important thing is to get it right locally, and it is this collaboration between primary care, the oncologist, social care, voluntary sector locally. Where we have that coordinated care, which is the secret of the Midhurst model, it works really, really well. But you can't deliver the service if one of those components is missing.
Can you put in place, I mean, that's what we were talking about, localism, either locally or regionally or nationally, can you put in place a structure within which it is expected that the delivery of health care and social care is going to be provided in ways that solve the problem?
Yes, you can. If you look at Staffordshire, we're working with the 5 CCGs in Staffordshire, all the providers of end-of-life care in Staffordshire, to run it as one system. And because the less time we spend talking about boundaries and budgets, and the better the care for people in that community is.
Staffordshire, of course, is somewhat bigger than Midhurst. Is it something that is actually beginning to work there as well, that can be rolled out, as they say?
Too early to tell, but the key to it is getting everybody to collaborate and play nicely together. Once you crack that and build that
and does that take government initiative, or can it? Are all the, as it were, the keys all in place? They've just got to be unlocking the same door at the same time.
To be honest, I think there's a role for the voluntary sector in this, because many clinicians and many commissioners behave better when we're in the room. So if we get the patients in the room, get the public in the room, get local representatives in the room, I think we can make some significant progress on this.
But what happens when you leave the room?
If we've trained them well, they'll behave.
We'll go to our next question.
No, I don't say
I'm not saying it's
what would you say? I don't know what the number is. There will be a shortage. No one simply don't know the answer to that question. I don't think it's possible to map there will be a shortage. We are asking, we're looking at implementing minimum staffing policy and then saying we can't have a minimum staffing level